Now, so we've done hypersecretion and hyposecretion of the anterior pituitary hormone and the posterior pituitary hormones. If you recall, I said that pituitary tumors can also present with compression symptoms. And those compression symptoms are headaches and visual disturbances. And the visual disturbances classically are bitemporal hemianopia and with persistence, optic atrophy, tunnel vision, and then blindness. So when we are investigating a patient who has a potential pituitary tumor or a space-occupying lesion within the pituitary gland, we look for and do an MRI of the brain. So anybody who has pituitary dysfunction symptomatically, we do an MRI of the brain to rule out tumors. Patients who have cranial diabetes insipidus have a specific sign when you do an MRI. They have loss of the bright spot that is normally seen where the posterior pituitary gland is. And this is pathognomonic of cranial diabetes insipidus. Serum acetylsarcoidosis and tumor markers of beta-HCG for other tumors. So, pituitary tumors are divided into two types: macroadenoma, where they're greater than 10 millimeters in size, microadenoma. Pituitary tumors may be functioning, that is, they're secreting excess and anterior pituitary hormone, or they may be non-functioning. Just to remind you, what do you anticipate in a patient who has a pituitary tumor? 26% of the times they're producing prolactin. 30% of the time they're non-functioning. 15% of the times they're producing ACTH. 15% of the times growth hormone. 12% of the times plurihormonal, that is more than one anterior pituitary hormone is being secreted. Growth hormone and prolactin, for instance, ACTH and prolactin, for instance. And very, very rare, never seen it. 2% of the times they are secreting TSH. Prolactinomas, you've heard me speak before about that, cause galactorrhea or hypergonadism. And we use the level of the prolactin, basal prolactin, to give us an idea of whether we're looking at a macroadenoma or a microadenoma. Macroadenomas, the prolactin levels are very high, 1,000 to 10,000 nanograms per ml. Microadenomas, they're relatively low, 100 to 300 nanograms per ml. The normal in females is 23 to 23, in males up to 25. When the prolactin levels are less than 100 nanograms per ml, it doesn't mean that that pituitary tumor is truly secreting prolactin. They may actually be compressing the pituitary stalk. Anybody understand the mechanism of this? If the tumor is compressing the pituitary stalk, the hypothalamic hormone cannot move from the hypothalamus to the pituitary gland. What is the hormone that suppresses prolactin secretion? Prolactin inhibitory factor. Okay? Okay, fine. Now, non-functional pituitary tumor, we now realize many times actually do secrete hormones, LH, FSH, or the alpha or beta subunits. If you have a TSH-secreting pituitary adenoma, how does it differ from primary hyperthyroidism? Well, you see the increased FT4, but your TSH is not suppressed. In primary hyperthyroidism, where the thyroid gland, for some unknown reason, is producing excess thyroid hormones, the thyroid hormones with feedback, short loop, long loop, to the hypothalamus and pituitary gland, and your TSH would be lower than normal. Remember that? Okay? If you have a TSH-secreting pituitary adenoma, your thyroid hormones are high, but your TSH is detectable. And that is classical for TSH-secreting pituitary adenoma. Sometimes the patients also have an outer subunit in 80% of the times, and when you do your TRH test, there's a twofold rise in TSH in more than 80% of the patients. Rather, that twofold rise which you expect is not seen in more than 80% of the patients. Sorry? Free diroxin. Oh, sorry. Yes, thanks for reminding me. Okay, so we do the MRI, magnetic resonance imaging, which is more sensitive to evaluate the pituitary gland than a CT scan. And when we do the MRI, we're interested in the optic chiasm. Why? Because it's going to, if the tumor suppresses or compresses the optic chiasm, you're looking at by temporal myopia and risk for blindness. We also want to know if the tumor is extending outside the extracellular. And we also do visual fields by perimetry. What do we expect?